For a woman experiencing severe or chronic pain, seeking treatment should be their only concern. Sadly, many women go without the care they need because they can't afford it and it isn't covered by insurance. Today, Dr. Cheryl Iglesia and Dr. Peggy Ye will help us understand why so many women go without the care they need and what we can do to advocate for more affordable care.
Welcome to Sex Care is Self-Care, a conversation for women's sexual health, brought to you by the Patty Brisbane Foundation for Women's Sexual Health. I'm your host, Patty Brisbane. Today we are discussing why so many women go without the care that they need because of the struggles to afford it. I'm joined today by Dr. Cheryl Iglesia and also Dr. Peggy Ye. Dr. Iglesia, let's start with you. And will you tell them who you are and what you do on a daily basis?
Sure thing, Patty. I'm Cheryl Iglesia. I'm the head of urogynecology for MedStar Health, and I'm a professor of OBGYN and urology at Georgetown University School of Medicine in Washington, D.C. I'm really happy to be here.
Yes, so I'm also an OBGYN in Washington, D.C. at MedStar Health. I am double boarded in OBGYN as well as complex family planning. And so part of my daily life includes providing full spectrum reproductive health care, including contraception and abortion. And I do a little tiny bit of research on the side with expanding contraceptive access.
That's awesome. Well, today is a very important subject, and I'm going to start off with a personal story. I hope that's okay with everybody. This is a subject that, unfortunately, it impacts a lot of women. This past summer, my granddaughter, who suffers with endometriosis, went to see one of the top specialists. And the sonogram that the doctor insisted that she had, that was much needed, by the way, was over $2,000. The insurance covered nothing but $200. And I sat with her at dinner the other night, and she was so upset. And she just said, you know, Mimi, I know that I have family that can help me out with this while I go to college. And she said, but what about the women who don't have people around them to help them? Dr. Iglesia, I'm going to start with you. Why are women left to cover so much cost for necessary tests and treatments out of their own pocket? Not fair.
Oh my goodness. This is such a hot button topic. And we, as physicians and surgeons, we want to take care of patients. And obviously I love to take care of them regardless of their ability to pay. But the economics of healthcare in the United States, it's so messed up on so many levels. Patty. First of all, I think we have about 9% of Americans that are totally uninsured. You have people working sometimes 1, 2, even 3 jobs, all for minimum wage, but all without benefits. There's also the gig economy. They're all without they're working, but they don't have health insurance benefits. Unless you're something like 200% below the federal poverty line, sometimes it's hard to qualify for the federal programs like Medicaid. And then you have to be over 65 to qualify for Medicare. So there's this gap with the working people who are the working uninsured. Then you get the people, and I'll even say it in my own family, we are insured, but sometimes there'll be some things that are non-formulary, out-of-network, uncovered services. We know, and as a urogynecologist, I know that there are certain drugs that are better for some people, but these drugs are not formulary. And let's face it, the insurance companies are really being paid not to insure us to get health care. We've just gone through a pandemic where the last 3 years, people didn't use healthcare and they got record profits. These insurance companies are making record profits. And the reimbursements, which generally follow Medicare and Medicaid services, have been decreasing to both physicians and hospitals. So the margins for a lot of us who are in healthcare and who work at hospitals have significantly decreased, while all the costs and the supplies have significantly increased, that it makes hospitals and healthcare kind of lower than grocery stores and used car shops in terms of the margins of what we make. So then you get the other people who literally are underinsured, and you want to go to see a specialist, and these are out of network. And I don't know if that's what happened in the case with you and your granddaughter, but and that brings up another question. You're out of network, but maybe the people who are out of network have more experience in the specific endometriosis or something else that you are specialized, you need specialized care for, and you don't have access to it. So I don't know. It seems that we need an overhaul. We don't need to make millions of dollars as physicians and surgeons, but it takes a lot to get to where we are. And there's a lot of students and residents and fellows who have significant debt. It's kind of messed up that you're starting off with six-figure debt. At the same time, can you run and operate a whole hospital when your margins are 1% and well below the cost of living adjustments that are occurring each year? It's kind of like not set up for success for patients and providers.
Well, you are right on a lot of that. I mean, she goes to Tucson, at the University of Arizona, and we went to Phoenix because there was a specialist that was there. And, I can remember her crying on the table because she said, Mimi, I've been to 7 other doctors and nobody has ever been able to give me a plan until now. So you're right. We sought a physician that could really truly help this girl. And so, and it's not just her. I've heard this on many other occasions where people have really had to travel to get help. So with that being said, it's really, really sad. Do you think this affects younger women, women of race? Who does this, or all women? Talk to me about that.
All right, let's just talk about it. So younger women, and Peggy will probably touch on this when we talk about family planning and stuff. If you are pregnant, you get covered for like 9 months of care and 6 weeks postpartum. And then after that, you're like dropped like a hot potato if you don't have regular insurance. That's kind of messed up because it's at that point that you almost need more help. Number two, a lot of private insurers will drop coverage for people after the age of 26. I think they were able to, like the Affordable Care Act, whatever, get to up to 26. But if you don't have a steady job that provides insurance, and that there are a lot of companies that don't give insurance now, they're just minimum gig type work, and it's prestigious, or it's kind of in the field that you want, but it's, Uber doesn't give insurance, for example. I'm just saying they're working and they're uninsured or underinsured. And that does disproportionately affect people of Black and people of color. And it goes on to the point that we have multiple studies, and I'll tell you about one that we recently did, looking at hysterectomy and the social determinants of healthcare. These social determinants, your social and economic status, can affect not just access to specialists, but increase complication rates when you end up and when you do end up having like operative procedures and such, because you don't have access to people who do things in like the way that may be least complicated and best for the patients. For something like a hysterectomy, we have patients that are getting very invasive procedures for things that we know you heal better, you do better, there's fewer complications, there's less blood loss, there's quicker return to function if it's being done in a less invasive, like minimally invasive way, like laparoscopically or vaginally or robotically, et cetera, as opposed to big incisions that take a long time to heal and have much more complications. But the bottom line is that access to just affordable healthcare and to the specialists that you need is key to health and to a healthy quality of life and longevity. And we just don't have it for all US, for everybody in America, we just don't have it.
Do you think some of these adversities are keeping people from taking care of themselves, like going if a doctor says, hey, I think I really can see that you need a hysterectomy, or you need a biopsy, or you need this? Do you think because of insurance that people are saying, I'll just wait till it's an emergency before I go?
Oh, absolutely. It's not even just with healthcare. I mean, it's dental care, it's eye care. The bottom line is like the preventative services, people have these plans that could be very high deductibles. And so you don't want to use it because you have to pay $5,000, before you can even get insurance to start covering it. Well, that's sort of that's a setup for disaster, because we want to treat a little skin lesion when it's early, like an early basal cell or early melanoma, before it gets really big. And I see this happening day after day after day. I'm not sure if it's really sustainable. I don't think anybody's really talking about it. And then, people will say, oh, that didn't work, or I tried that, they didn't try this, or like we want to refer someone to like physical therapy that would help them, after the baby is born. Well, the it's not covered, and they don't have the $100, $200, it's some. And then if you have places that take insurances, the wait lists are too long. I'm embarrassed to say, people sometimes have to wait 6 months to see me or some of my partners. That's embarrassing. That's not right, with your bladder falling halfway between you. So there's a lot, we don't have, some areas are under doctored. Others just, it's unaffordable to reach the care that you want. And then once you get something recommended, like I'll say, oh, we should get an MRI, just whatever, the insurance isn't covering the MRI, or I have to spend an hour, or someone on my staff, with the insurance company telling someone why we think that this is important. That's number of prior authorizations that we have to do to help our patients jump through some of the loops. Like, I think this drug is better, but it's going to take me 20 minutes to be put on hold and talk to the doctor or whoever. Maybe I don't even know if they're a doctor, that this is the right. Maybe it's a doctor, but it's not a gynecologist. As to why this is appropriate. It's not right, Patty. They're doing everything they can so that people, and I would say women and children a lot, don't get the care that they need.
This is a really difficult subject. It is. It's embarrassing. It is embarrassing. It's 2023. We should be much further along. Dr. Ye, is contraception something that is often not covered by insurance, so we can bring more kids in the world that can't be taken care of? Just throwing that out there.
Right. I know, right? So luckily, contraception has made huge strides. Now, that is explicitly because of the Affordable Care Act. So pre-ACA, there were definitely a lot of barriers. Most of the common birth control methods, contraceptive methods, were covered, but a lot of the newer things may not have been. The more expensive devices, like intrauterine devices or implants that were really highly effective, were often not covered. And a lot of insurances also did other things to restrict the types of contraceptives that you could use. So they would have tiers where certain types of methods would be covered at a lower price, or at a cheaper cost to the patient, and some others would be more pricey. And then sometimes they even required what they called step therapy, which would require you to fail a contraceptive method, I assume, meaning that you have an unplanned, unintended pregnancy, before they would cover something else. Thankfully, with the Affordable Care Act in 2012, they put in this contraceptive mandate that required all commercial insurances to cover all FDA-approved contraception with no cost sharing. So no copays, no other prices. That had to be free for the patients. And so since that has really made a huge difference. And most contraceptive methods are free. Not all, but most contraceptive methods are free. There are certain exceptions, of course. And they're actually subject to ongoing litigation. Not to get too, in the weeds, but there have been a lot of lawsuits against the Affordable Care Act. It makes the news every time there's a new lawsuit. But in the past, there's been religious exemptions for the contraceptive mandate. So churches, religious organizations, and even companies that, really strongly believe that contraception is not appropriate can opt to not cover the contraception. And then there's actually I was recently reading about the current case against that's going to make its way probably to the Supreme Court, but there's a lawsuit against the preventive mandate. So the Affordable Care Act had required all preventative measures that's recommended by the U.S. Preventative Services Task Force to be covered at no cost. And so now there's a lawsuit going against that. And so that may include contraception, that may include like hypertension medicines, who knows? So we're kind of moving backwards. But in general, most methods were covered, but who knows what's going to happen?
Yeah, who knows? Unfortunately, when the treatments are so expensive, I think that many women choose not to seek treatment at all. What could be some of the lasting impacts that can be on their well-being? Dr. Iglesia, we'll start with you.
All right. Well, that's, I'm listening to Peggy and I almost want to cry a tear.
Yeah, I know.
This weekend is the 60th anniversary of the March on Washington with Martin Luther King. And this morning I heard, as I was getting ready for this, and this morning on the news, that Martin Luther King's granddaughter has fewer rights now than 60 years ago after this incredible march. And here's the problem. When we know that there are treatments that may be a little bit more expensive, and let's bring the IUD, it's called a long intrauterine device. These are progesterone-containing devices that you can place in the uterus. They're called long-acting reversible contraception. We're far away from the Dowcon shields when gave IUDs a bad name, mostly because the string attached to it was made out of multiple filaments and led to a lot of pelvic infections. But we have significant evidence that the use of these long-acting reversible contraception can prevent chronic pelvic pain conditions, including endometriosis, that by preventing these monthly bleeds and the buildup of the endometrium in places outside, that's the lining of the uterus, outside of the uterus, and these painful periods, I think that this becomes a real problem. People need to have access. And, if things aren't covered, they can't afford it. We're going to pay more way down the road for these conditions of chronic pelvic pain. It makes no sense to me. Not to mention the whole family planning aspect. And I know one of our segments later is about sex and the media and how things are depicted. But the bottom line is that we need to use the knowledge and the technologies and to have access to these things to prevent chronic conditions that affect women at a very high rate and have significant impact. Like, you were talking about your granddaughter and endometriosis. I don't understand why this is not happening and why is this becoming such a political issue? Because we want people to live a very healthy quality of life. Yeah. Lasting impact on well-being. Are you kidding me? Yes, that is not right. Right, Peggy? I mean, tell me how much these IUDs
right. So, it really doesn't make any sense. And especially to me, like if you're an insurance company, there's been plenty of studies that show, that family planning, contraception is cost saving. So for every dollar you spend in family planning and contraception, you save at least $4, if not even 10, in downstream, problems, health conditions for the patient, for their children, other chronic conditions. And so it seems like a no-brainer to me that an insurance company should cover this. But an IUD certainly is very expensive. I think something like $800 each. If the person has to pay any portion of that out of pocket, that's really inaccessible for most people, including me. And I have a good job.
And I have to tell you, for doctors too, we have to be really careful because we carry these devices in our office, but they have a shelf life. We can't be having too many because it's just a terrible process that we have to go through on both the patient and the provider, trying to do the best thing for women. We can prevent heavy menstrual bleeding. I mean, I know we have segments on this, and the anemia and the transfusions and the major surgical procedures that end up needing to be done for this heavy menstrual bleeding with devices like this are adequate. Contraception, that even the advanced contraceptives that can have a period like once every 4 months or so, once every 3 months, once a season or something. We have all this technology, and I'm not sure why we have to go through so many loopholes to get it the right ones for our patients and then tailor it to that. So big problem. We need to advocate more. I'm glad we're doing this segment.
I am too. It's been a little more than a year that Roe versus Wade was overturned.
June 24th, 2022.
How has this affected access to reproductive health care? Peggy, can we start with you?
Yeah, of course. I mean, it's been a year, so we're starting to see all how everything's playing out, but it's still definitely a changing landscape. Every month there may be a new state that institutes an abortion ban or institutes other restrictions. And it's not just abortion. It's, certain types of reproductive care. It's other trans care, gender affirming care, and they are just expanding. So the immediate effects, of course, patients are traveling a lot further, maybe 3 times. I think initially there's estimates that they were traveling 3 times further to get care. And there's a lot of networks trying to get patients to states that abortion or other reproductive health care is banned to states where it's not. It feels like it's like networks in the 1970s, right? Trying to get patients to travel and paying for their travel and finding, safe houses for them to go to and stay while they're getting their procedures done. Locally, clinics are overwhelmed because they're taking on this additional load as well as taking care of the local patients. We're just now seeing the maternal health effects because, it's just now 9 to 12 months and seeing any complications for those pregnancies that high-risk pregnancies that couldn't get care that they needed, high-risk pregnancies that may have been recommended for termination but couldn't under new laws. It expands to non-abortion care too. I'm sure everybody's heard all these news stories about people being hesitant to treat ectopic or tubal pregnancies, which can be really life-threatening, miscarriages, people getting blood transfusion because they've been bleeding because nobody's willing to treat their miscarriage for fear of, being accused of doing an illegal abortion.
I'm just going to state it. I think government should stay out. This should be left to the doctors, and that is bottom line. And do we really want to sit back and watch our kids and our grandchildren and all further generations continue to experience this downfall and not knowing how to take care of their bodies? I mean, is this what we want?
Absolutely not. And we really need to squash the misinformation. That's what bothers me the most when I hear politicians talking about that you can put the ectopic back in the uterus. Excuse me. And that we have abortions, full term, partial birth. There's so much terminology that is actually factually wrong that people are using that bring up the emotion. Of course, we don't do, partial birth abortions. And, I think that we need to educate the women. To be quite honest, I think more women should be running for office as well, so that we can have a seat at the table. And so people can understand what contraception is and the non-contraceptive benefits from contraception, like the prevention of endometriosis or heavy menstrual bleeding. And understand that as doctors, we cannot be practicing our craft and also be handcuffed because of legal-based medicine. What we practice and the oaths that we take to be board certified, double board certified, whatever, physicians and surgeons are to practice evidence-based medicine and to see a patient that we know has a non-viable pregnancy. I'll give you an example because there's been lots of cases about this and in courts. Miscarriages, water is broken at 16 weeks. That's not viable, but the baby has a heartbeat. Why the heck are we waiting on that to the woman to get septic, potentially become die or lose her uterus? And these are things that have happened because providers are not able to practice what they know is the right and ethical thing to do, and risk being, courted off to jail or had lots of time in a court of law to explain this. This has got to stop. The politicians, I don't know what they're trying to do, win votes at certain sectors. Let's just say that has got to stop. And doctors can't even be second guessing themselves when it comes to trying to save a life. I don't get it.
What is it that you think that we can do to lobby against insurance companies and these and treatments that need to be covered, and having the government stay far away from what doctors know best? Because they didn't, that wasn't their forte.
Yeah.
They didn't go to school for this. They don't know. They're just guessing when they, okay.
Peggy, you
Well,
take it.
Cheryl definitely had the right thing. This is, a huge wake-up call for women these days. And we've seen that, a lot of these voter initiatives in states have really gone to affirm reproductive rights, despite what their legislature is trying to do. And so this is kind of one of the things where it's like a call to action. Everybody needs to run for office or be more politically active, talk about it more, talk about, their problems, the access that they can't get, the access that they can't afford, the barriers that insurance has put into their care that's unnecessary and medically unsound.
And honestly, and Patty, I was the immediate past president for Society for Gynecologic Surgeons. And right when Roe came up, we did a major survey of leaders in OBGYN, and we've done some follow-up focus groups about the impact of Roe on training, particularly training in gynecologic surgery. There are 44% of the OBGYN residency programs are in states where there's restricted access to abortion. Therefore, trainees cannot learn techniques that we use for other things, like when people have real miscarriages and stuff. And you need to learn how to do that to save people's lives if they're having abnormal bleeding, stuff like that. And they're having to go through hoops to go to other states to learn some of this stuff, even down to learning how to do ultrasounds, for the diagnosis of where abnormal pregnancies are located with in the early first trimester when there's bleeding and stuff like that. There's so much we have to do, and now we have concern for our ability to do medication abortions just because of access to that, and inclinations that potentially the way that these drugs were approved by the FDA initially 30 years ago was false. I just feel like we have to stop this, because this is not right. We want to have the best trained physicians, surgeons, OBGYNs in the world so that we can take care of U.S. women. And I'm afraid that that's going to significantly be impacted, which is why the SGS has, written papers about this, and I'm, tried to give some evidence and some, show what's really happening, not in theory, but what's really happening in the arena, in the OR, in the clinic, in the clinic room, in the office. It's not good, and it makes me worry.
So let me
I'll
ask you
also say
this.
that.
Go ahead.
Go ahead.
No.
Oh, yeah. That as doctors, a lot of times we go into this focusing on patients, focusing on taking care of patients, learning all the medicine. Now, I think we're all being thrown into a realm that we don't necessarily want to or be comfortable with being in. Advocacy, talking for our patients, advocating for our patients. There are. I was hearing in Idaho, there are like maternity wards that are closing because they can't keep OBGYNs there because they don't want to practice in that state. Those doctors need to
We have it here too.
start being more vocal, right? So that's the other thing is that we start, it's a wake up call for the physicians too.
Yeah, you're going to be creating medical deserts because if doctors don't want to go there because God forbid they should have a problem or their significant other should have a problem. I'm stuck in a medical desert. It's crazy.
This is really a very sad time for women. It really is. And if we do not start using our voices,
yes,
it's gonna continue, and it's gonna continue for generations to come. I mean, I've got one last and final question. So, if a patient comes in and you give them, you tell them exactly what you feel that needs to be done, is there any room to find another solution that is less expensive?
Yeah. So, fortunately, there are some workarounds. Like, for example, when there are drugs that we're recommending, there are coupons, there's certain services, like Mark Cuban has stuff that you can maybe find some other options that at least you can trial. There are certain companies that have compassionate care and will, just like in chemotherapy and stuff like that, will give things for free, at least on a trial basis. But it does take time to fill out the forms and to do these. And then obviously, depending on how passionate we are in our time, many, many doctors, despite the fact that it takes a lot of time, will fill out the paperwork. They will make the calls. We have our medical office assistants, our nurses, nurse practitioners, APPs, working this on a regular basis, free of service, just so that we can advocate for our own patients because it's not right. And we're going to continue to fight for it. I wish we didn't have to do that. And it's the bane of a lot of the existence for us to do our services, and it probably leads to some of the burnout. At the same time, it can really impassion us, make us more passionate, and get so angered by this that, hopefully at some point, something's got to give, Patty.
Something has to give, because I wouldn't want your job right now. I mean, you've got it. This isn't easy.
And Peggy, as a specialist in her area, and we have lots of states that have restrictions. West Virginia, that are, people coming from as far as Louisiana, and when you have people flying in from like Texas and Mississippi, don't you, Peggy, taking care of it. And there are sad stories where they take care of it and it's too late. Don't we have stories, Peggy? The residents are telling me.
Yeah, we're definitely seeing a lot of care that's later than patients would want to be. But I will agree with Cheryl. We sometimes don't even know what insurance companies will cover or not. They're very opaque. They're very opaque to us sometimes. If the patient calls the insurance company will tell the patient one thing, and then they tell us something completely different. So it's a lot of work around with the patient and the pharmacies and the insurance companies trying to find something that's going to work for a patient. So, good lines of communication, having the patient be open and frank about charges that may or may not be happening. And we are taking this fight. The American Medical Association is doing a big thing about fighting prior authorization that are unnecessary. I mean, I think they looked at a study and prior authorizations are approved more than 90% of the time. So then why are we doing it?
Right.
Just to add another loophole to our, trying to do the right thing. I hope we can have a podcast next year and see if, as a follow-up part 2, that we can put more of a positive spin. This is an election.
Me too.
I'm a little depressed this morning.
I know. I'm sorry.
but we gotta change that conversation so it's more pro women's health. And so because it's an election year and people are can vote and call people out when they're saying misinformation. I think anytime we need to call it out and say, no, that is exactly not right. That is not exactly no.
There you go. Get out, vote, and speak up and speak out. I think that's so important.
That's what you do, Patty. You do that one of the best.
Well, I learned from the best. So I want to thank my guest, Dr. Cheryl Iglesia and Dr. Peggy Ye, for a great conversation. And if you like what you heard today, please rate and subscribe to our podcast. For more information on the Patty Brisbane Foundation for Women's Sexual Health and our focus areas, visit the pattybrisbanefoundation.org. Remember, sex care is self-care and sexual health matters.